Hey there everyone, it's Adam again, and today we're going to be covering Unit 4 of the class. This will be covering mainly the topics of adverse drug reactions. We'll talk a little bit about bioavailability and then also bioequivalence. So the first thing we'll talk about here is going to be adverse reactions to medications. They can be kind of defined as an appreciably harmful or unpleasant reaction that occurs after using a medicinal product to intervene in some sort of health issue. And so, based on the type of adverse reaction we see occurring, it helps to predict hazard from future administrations and may warrant a few different kind of courses. Could be using preventative or specific treatment in order to counteract the adverse reaction. Could result in alteration of the dosage regimen. It could either be dose or it could be frequency that the drug is given, or it could mean that you have to withdraw the product altogether. And so we'll see that based on the type of reaction that they're having, and based on things like the mechanism of the drug or the kinetics of the drug, you'll see that usually one of these three routes have to be selected. And in which case, if you had to withdraw a medication completely, you may need to intervene with a different medication, maybe from a different class, in order to still get the same therapeutic effect you were looking for in the first place. You can break down adverse reactions into several different categories, and you kind of use this A, B, C, D, E, F mnemonic in order to keep the different types kind of in your mind. So the 6 categories that we'll go over include those that are going to be dose related. Those will be augmented effects that you see from the drugs. That's the A there. You can have these kind of idiosyncratic non-dose related effects, be bizarre for B. You can have those that are going to be dose related and time related, so these are going to be more for chronic reactions that occur to medications over a longer period of time. You can have those that are delayed or time related, to where the adverse effect may not initially show itself upon initial dosing, but over time may pop up later. You can have withdrawal of therapy, can lead to some adverse reactions, and also just failure of therapy itself. So that's kind of the 6 different types. And so we'll kind of drill down more onto these and see what each of these entail. So the first group we'll talk about are going to be the dose-related or the augmented reactions to medications. And so several caveats to this. This is probably going to be more of the common ones you're going to be faced with as practitioners. Either the dose is just going to be too high, or if the patient is taking it incorrectly, you can see issues with this popping up. Generally, this is going to be related to the pharmacologic action of the medication. You'll see this is typically going to be more of a pharmacodynamic type of reaction we're going to be seeing, just due to too much drug being around. It's pretty predictable for the most part, and generally have low mortality for the most part. Again, if you can catch these earlier on, you're more likely to either change the dose of the medication or do some sort of intervention in order to help prevent further morbidity and mortality from occurring. And in this category, you would also include things like general side effects, kind of anticipated things that you would expect from the medication based on what's been found in the clinical trials, or based on what's found which is common use of the medication in the general populace. So good examples of these would be things like sedation that you see with first-generation antihistamines. So if you've ever taken something like diphenhydramine or Benadryl for your allergies, you may notice that you get sleepy with a dose of this. It's related to the anticholinergic effects that it has within the CNS. So it's something that we can predict based on this pharmacologic action. And it's fairly common for most people. In fact, some people will even take first-generation antihistamines for sleep. So something like doxylamine or Unisom is marketed directly for that. So in some situations, you may see adverse reactions may be an actual therapeutic action in some cases. Other effects that could fall in this category would be something like hypotension, seen with the use of calcium channel blockers. This category of drugs is typically used as an antihypertensive. And so you can say give 1 dose of a medication, say 30 milligrams of drug A, to a patient in order to help bring their blood pressure down to kind of normal levels, quote unquote normal levels. But if you were to increase that dose, or say for instance the patient was elderly and didn't realize they had taken their dose already and had the double dose, well, now that you have a higher dose on board, you can end up seeing hypotension develop from that. So again, it's kind of an extension of this pharmacologic action, and again, something that's predicted based on kind of the exposure the patient's getting there. a lot of times these can be dealt with by decreasing the dose or maybe decreasing the frequency with which they're being given. In some cases, though, you may need a different type of medication altogether. So say, for instance, if you have sedation with first-generation antihistamines, that's really not something you can get around with that particular type of drug. So in that situation, what they did was come up with second-generation antihistamines, which actually lacked the sedative effects that the first generation does, because they actually changed the chemical structure of those molecules and made it so that they cannot cross into the CNS. And so since that's where a lot of the anticholinergic effects were being seen causing the sedation, if you prevent the drug from ever getting there in the first place, then you don't have that adverse reaction that's occurring there. So that would be one instance where a different type of or different category of medication would be used if the side effects are so bad with one type of medication you can't get away with using them. You can have non-dose related adverse reactions as well. We'll call these kind of the bizarre reactions. These are typically going to be uncommon things that are occurring. It's not going to be very predictable for the most part, and a lot of times you won't see it necessarily being related to the pharmacologic action of the medication. Typically, because these can't be predicted and these can't really be a lot of times you can't screen for patients for this necessarily. You may see higher mortality just because the reactions may be pretty severe, and you may not be able to necessarily catch it early enough in order to prevent kind of really significant morbidity and mortality. So a good example of that would be something like allergic reaction to penicillins. You can't predict who's really going to have a reaction to penicillins unless you did skin testing on everyone. So this is usually something that you would just prescribe to somebody, and as long as they don't have a history of allergy, and you just may find that unlucky patient that happens to react to it. Again, not something you can necessarily screen for all the time. Another good example of this would also be malignant hyperthermia that can be brought about by patients receiving general anesthetics. So this would be like inhaled anesthetics like sevoflurane or isoflurane for general anesthesia in surgery, or also a paralytic called succinylcholine that's typically used for rapid sequence intubation of patients. Some patients happen to have a genetic predisposition with one of their ryanodine receptors, to which they'll have kind of a very exaggerated effect when exposed to these medications, and they develop this life-threatening emergency called malignant hyperthermia. Basically, they develop very tense muscles. The muscles are contracting more so than they should. You develop a lot of acids. You develop a lot of hyperthermia from this, and very well could be life-threatening. So this is one of those things where if there's a family history and you screen them appropriately, you may be able to avoid giving these specific medications to certain patients based on this history. Otherwise, you're kind of going blind, and you may get one of those unlucky patients that happens to have a reaction. So again, not something you can do necessarily to prevent these from occurring in the first place all the time. But again, in certain circumstances, you could screen patients and try to avoid giving it to those more high-risk patients if possible. We have the dose and time related, or the chronic adverse reactions. These are relatively uncommon and typically will result from kind of a cumulative dose of the medications being received by patients over a prolonged period of time. So a good example of this would be adrenal suppression with corticosteroids. So say, for instance, you have an inflammatory condition that's going on, say an asthma exacerbation, that can be treated with the use of corticosteroids, things like prednisolone, prednisone, methylprednisolone, hydrocortisone. These are all good examples of corticosteroids that have anti-inflammatory properties by mimicking the effects of adrenal hormones. So what happens to the body over time is that if you have a high enough dose of these steroids on board for a long enough period of time, your adrenal gland kind of senses that, hey, there's enough corticosteroid action going on here, I don't need to produce it myself. And so you'll end up having adrenal insufficiency develop over time, because again, you're supplying that corticosteroid action exogenously. Well, if you were to withdraw that all of a sudden and stop giving the medication, your adrenal glands need time to really ramp back up their production of corticosteroids. So if you don't give it that time to do so, by tapering your dose of the exogenous steroids, then you can put the patient at risk for adrenal insufficiency, which can potentially be life-threatening. So this is why a lot of times with corticosteroids, if patients are on it for, say, over a week, you'll actually see them have tapering schedules alongside with that. So again, they'll be on, say, pulse dose steroids for, say, a week or so, and then they'll have another week where they'll actually be titrating down off the dose to give the adrenal glands time to kind of ramp production back up. But again, this is something that's related to chronic use of the medication that happens over time. Just one dose of steroids is not enough to make the adrenal glands completely shut down. But certainly if I was giving steroids for 2 weeks, that may be enough to really cause a significant insufficiency. You can have time-related or delayed adverse reactions. Again, these are similar to the non-dose related ones in the fact that they're fairly uncommon, and you generally don't see it being related to the dose that's being administered. And again, this is going to be occurring or becomes apparent sometime after the drug has been used for a period of time. So a good example of this would be things like teratogenesis. So say, for instance, you had a patient who was receiving valproic acid for seizures or for bipolar disorder. If they did not either inform you that they were pregnant or they were not aware of the fact that they became pregnant, you could end up developing neural tube defects in the fetus, which may lead to non-viable fetus, or it could lead to some significant birth defects. So this would be something that would not be apparent with the mother's use of the drug, but wouldn't become apparent until the birth occurred, or whatever it was, kind of let you know that, hey, there's some adverse effects happening here. Another good example would be tardive dyskinesia seen with antipsychotics. This is a condition that occurs with chronic administration of antipsychotics that block dopamine receptors. And again, it's not necessarily related to the dose that the patient is receiving, but is more related to the duration of therapy. And if it goes on for a prolonged period of time, that's where we start to see these adverse effects pop up. It's one of those things where if you know that a patient is going to be at risk for one of these delayed adverse reactions, potentially you could limit the duration of time that the patient would be on the medication, or try cycling off to a different type of medication that may have less chance of causing similar side effects. So obviously with teratogenesis, one of the big things you have to do is make sure you're practicing safe sex and appropriate contraception in order to prevent the potential fetus from being exposed to the medication. So either use medications that are safer for a fetus, or make sure that the people are using appropriate protection in order to prevent that from occurring. With something like tardive dyskinesias with antipsychotics, this would be a case where you can actually use a different class of medications, something like a second-generation antipsychotic, in order to help prevent this from occurring with more chronic use. You can see adverse reactions with the withdrawal or the end of use of a medication. Again, fairly uncommon for the most part, but you will actually see that when this withdrawal occurs, a lot of it depends on the drug's half-life and how abrupt the withdrawal actually happens. So things with longer half-lives, things that are going to be sticking around the bloodstream for a longer period of time, they kind of have this nice natural taper down effect where their drug levels will taper down over a long period of time, which leads to less significant withdrawal reactions. So for a good example of this, looking at antidepressants. If someone's on an antidepressant like a selective serotonin reuptake inhibitor like fluoxetine or Prozac, for a long period of time, you run the risk, if you discontinue the medication very abruptly, to end up having withdrawal effects. Patient become very agitated, have a lot of sweating and anxiousness and all these things. But by using a drug like fluoxetine, which has a very long half-life, you make it so that even if the patient abruptly discontinued use of the medication, the drug levels will stay high enough over a prolonged period of time to where they would not have as significant of withdrawal effects as if they're taking a different SSRI. Other types of drugs that can cause these effects as well include things like opioid. These are narcotic analgesics that after chronic use of the medication, your receptors really get used to having those receptors being activated with these narcotics. And so when you withdraw that, you can end up developing very significant withdrawal reactions. So a lot of nausea, vomiting, diarrhea, sweating, agitation. And so this is one of the reasons why, in order to help wean patients off of chronic opioid use, we'll use longer acting medications. We'll use things like methadone that have a direct half-life of something like 50 some odd hours in order to help prevent the withdrawal reactions from occurring. So again, there's lots of strategies to do where you do kind of slow tapers in order to help prevent those reactions. You can also have things like myocardial ischemia that can happen after abrupt beta blocker withdrawal. So we kind of mentioned this example before with receptor up and down regulation. So if I have a beta blocker that's on board chronically on the heart in order to help prevent prevent arrhythmias from occurring. Over time, by blocking those beta receptors, I'm going to have an upregulation of them to where I have an increased number of receptors available to be activated by things like your catecholamines, like your epinephrine. If I have abrupt withdrawal of the beta blocker, all of a sudden I have all these receptors around that can now be activated by these catecholamines. So what can occur is if you have a high-risk patient who was really requiring those beta blockers in order to help keep myocardial oxygen consumption down. When you remove that and have all these catecholamines activating those beta receptors, you increase chronicity of the heart, you increase the contractility, and that's going to increase O2 demand, which can lead to myocardial ischemia. So again, another good way to prevent that in the first place would be to have a slow taper of the dose and to use a longer acting medication in order to have a nice taper effect to where you prevent, you give the receptors time to start down regulating so that they don't have as big of a kind of a shock, so to speak, when those receptors are now not being antagonized by the beta blocker. You can also have unexpected failures of therapy. These can be fairly common in some cases. A lot of times they are dose related in the fact that the dose that the patient is receiving may not be sufficient, or they may not actually be getting the dose in the first place, especially if compliance is a big issue. These can be caused pretty frequently by drug interactions, and so that's why it's always important anytime you're adding on a new medication to a patient's regimen that you always are checking for significant interactions. So good examples of this would be something like calcium-containing antacids. So calcium carbonate's a very common antacid, otherwise known as Tums. And so a lot of patients don't even consider this a medication. You know, it's over the counter. They can just pick it up from the store. They may not even let the provider know that they're actually taking these with some regularity for their upset stomach or for GERD or whatever. So say, for instance, you were to prescribe them a fluoroquinolone, something like ciprofloxacin or levofloxacin. If you're not aware of the fact they're taking these calcium-containing antacids, you wouldn't realize that they'd have this drug interaction where the fluoroquinolones are actually being bound up in the GI tract and can't be absorbed into the systemic circulation. So obviously that's going to be a failure of therapy because the dose might not get high enough to actually eradicate whatever bacterial infection you're trying to treat, and so that could be a failure. You can also have issues with oral contraceptives may not be as effective if you were to have hepatic enzyme inducers. So, say for instance, a young lady's taking oral contraceptives. You add on something that ramps up her liver enzymes or CYP enzymes to where they are metabolizing more of those contraceptives than what would normally be occurring. Now, all of a sudden, her bloodstream levels of the contraceptives are going to be lowered, and thus that's going to increase your risk for failure and risk for pregnancy. So again, knowing those interactions, or at least running all of the patient's medications through an interaction checker, can be potentially lead to some very, very big impacts in medication safety for your patients. So again, looking at adverse reactions versus side effects, typically side effects are going to be kind of considered as an undesirable secondary effect from the medication, and it's typically going to be occurring in addition to the desired therapeutic effect of a drug. So say for instance, if you have someone who is taking a beta blocker for their hypertension, but it's also leading to some exercise intolerance. That may be one of those things where you have to kind of look at the therapeutic effect, like, okay, their blood pressure is in range. You know, it's in going by the guidelines, it's within range. It's preventing things like atherosclerosis and increased risk for heart attack and things like that. And so that's the therapeutic effect. But then you look at the exercise intolerance due to the fact that the heart can't beat quite as hard and as fast as it used to. That's going to be the side effect, right? And it's undesirable, but based on the benefits versus the risk of it, you have to make that judgment to say whether or not this is going to be tolerable by the patient. Because at the end of the day, if the patient can't tolerate it, they're not going to take it, right? And so then their blood pressure is going to be out of range, and they'll be at risk for other morbidities down the road, right? So it's one of those things where maybe by switching the medication, switching the type of medication, like instead of using a beta blocker, say a calcium channel blocker, might be able to mitigate those side effects while still maintaining a therapeutic effect, would be the better option for your patient. So kind of looking at it as we go through Farm 1 and Farm 2, you'll kind of see the different options that are available to you and kind of figure out why you might choose one versus another based on things like drug cost and tolerability as far as like how often the drug is dosed, but it may not be worth it for your patient if the side effects are too significant. You may need to switch for something maybe a little bit more inconvenient, but maybe more tolerable ultimately by the patient based on fewer side effects. Now, some side effects can be a good thing. So if you look at something like Latisse or bimatoprost, this is a prostaglandin that is originally used for glaucoma. It helps to decrease intraocular pressure. One of the side effects that they saw was actually that it increases eyelash length. So some people thought it was a really good idea to market it for this reason, so that's where Latisse comes from. It's marketed to increase eyelash length, have fuller, longer eyelashes, is a desirable trait. One of the other side effects that you may see from this medication, though, is that it actually may turn the iris brown. So unless you already have brown eyes, it's probably an unfavorable trade-off. So again, it's one of those things where weighing the benefits versus the risk may make the drug a good option for some patients, but not for others. Another good example of this would be minoxidil or Rogaine was originally marketed as originally intended to be an antihypertensive. Wasn't really great because it caused a lot of side effects, but one of the side effects was that it caused increased hair growth. So again, that's where Rogaine comes from. That's where it got its main therapeutic use from. Again, looking at the comparison between adverse reactions versus side effects, typically adverse reactions you would really consider to be a much more severe kind of reaction that is usually requiring some sort of intervention. So again, looking at the use of a drug called Bactrim, that's the brand name. The generic name is, it's a combination of sulfamethoxazole and trimethoprim. This is an antibiotic that's used quite frequently for skin infections, used for potential UTIs, lots of different things. Now, an adverse reaction to Bactrim would be Stevens-Johnson syndrome. This would be one of those things that's kind of idiosyncratic. You're not going to be able to really screen patients for this unless they've had a previous reaction. But basically, it causes very, very significant skin reaction where they start to slough off their skin. Potentially can be life-threatening if not caught early enough and treated appropriately and aggressively enough. That would be a significant adverse reaction. Now, say for instance you have a side effect, or an example of a side effect would be something like rash and urticaria, but only in sun-exposed areas. This would be kind of photosensitivity that you can see with the drug. It's maybe one of those things where it may be undesirable by the patient, but hey, if they cover up while they're on the drug or if they use sunscreen, they may mitigate it or prevent it from occurring in the first place, right? So that'd be a side effect that may be tolerable versus an adverse reaction like Stevens-Johnson syndrome, which is something that requires absolute discontinuation of the drug and the patient never to get that drug again for fear of this reaction coming back. Looking at some other examples, so Viagra or sildenafil, it's a drug commonly used for it's a phosphodiesterase inhibitor. It's commonly used for erectile dysfunction. Also can be used for pulmonary hypertension. A side effect of this would be upset stomach. Well, okay, the upset stomach may be tolerable by the patient if it makes their other conditions, the therapeutic effect is worth it. Maybe they can eat it with or take it with some food, and it may help them to limit the side effects. An adverse reaction that would be sudden loss of vision. Right, that would be something that would require immediate intervention. In this case, would be discontinuation of the drug altogether. And then something like an ACE inhibitor or an angiotensin converting enzyme inhibitor like lisinopril, a side effect could be cough, right? This is something that happens due to bradykinin buildup. For some patients, it could be totally intolerable and they do not want to take the drug anymore. It may necessitate using a different type of drug within a similar category. In this case, it would be an angiotensin receptor blocker. On the other hand, though, if you have an adverse reaction like angioedema, this lady here obviously has a case where her tongue is getting very, very swollen. Obviously, this could be life-threatening if it leads to airway closure. Patient may need to be intubated in order to help maintain that airway. This would be a case that would, again, require immediate intervention. So that's kind of your guideline for kind of discerning whether something is just a side effect versus an adverse reaction. So some of the things that we can do to help prevent adverse reactions, we always talk about the 5 rights of medication safety. So again, you always want to make sure you're following these. So you have the right drug, the right patient, the right dose, the right route, and the right time. This may sound super easy. The 5 rights may sound like common sense, but it can be much more difficult than you might imagine. And in fact, being in a hospital type setting can be a very dangerous place for patients in a lot of cases. So say, for instance, right drug. How hard is it to pick the right drug? Well, look at things like confusing brand names that come up. So if I have a drug that has 3 different versions of it, I could have an XR, I could have an SR, I could have an ES. What does that mean, right? What's the difference between an extended release, XR, versus sustained release, SR? Those drugs may be dosed completely differently. And if you get that incorrect, you may be giving too much of a medication or not enough, depending on how it's being dosed, right? You also have a lot of brand confusion with over-the-counter products as well, based on the fact that a lot of these companies want to use their brands in order to help make it easy for patients to always go for the same thing. But if a patient says they're taking Tylenol, what does that really mean? It could be Tylenol, cough and cold, which may include some other medications than just acetaminophen. NyQuil can be really bad for this as well. Is it NyQuil? Is it Dayquil? What type of medications are included with that? So just saying NyQuil, for your patient may just be a generic way of saying some cough and cold medication. It doesn't really give you a ton of information about what they're actually taking. One of the things I noticed as well, being here in Orlando, us being kind of a travel hub, we would oftentimes see a lot of foreign patients coming in that would get sick, come to the ER, and some of their medications would be have completely different names than you're used to. So for instance, if a patient is on salbutamol, that's just another way of saying albuterol, right? Paracetamol would be a common way to say acetaminophen if you were from Europe. So again, it's one of those things where having Google available makes it a lot easier than it used to be, but you can imagine, say 10, 15 years ago, patients would be saying these medications, you might not have any way of finding out what exactly they were. Certainly, I've had a few instances where I've actually had to take medication boxes for prescription products from, say, from Ecuador or Brazil or somewhere in South America, and basically I'd had to punch in all the information into Google and try to get a translation to try to figure out what the medication actually was and what they're taking it for. So again, getting the right drug and making sure that you know everything the patient's taking and what they should be taking can be more difficult than you may think. Making sure you have the right patient. This can be pretty difficult given that, depending on where you're working, say you're working in a pretty busy ER, there's a lot of turnover in ERs. You may have several Smiths. You may have several Rodriguez's. You may have several patients that have the same last name, especially throughout, a 12-hour shift. And so it's always important to make sure that we're using multiple identifiers to make sure we have the right patient before giving that medication, right? Not only that, but you have a lot of issues with siblings. Certainly from the pediatric standpoint, working in the NICU, you have baby boy A and baby boy B. Well, it's real easy to get those patients mixed up and give their medication to the wrong patient if you were not sure they had the right patient, right? So siblings can be pretty dangerous from that standpoint. And then patients moving around the floor. So you can oftentimes have lots of transfers from patients from one room to another. So certainly there's been instances where someone says, give that medication to 5113. Well, are you sure that 5113 is the same person it was 6 hours ago? Maybe a totally different person, right? So that's why it's really, really important to use at least 2 identifiers to make sure it's the right patient. And so in a lot of cases, we see technology helping us with this, and barcode scanning is super important. So most are in some organizations, you'll see patients that will be have a wristband that will have all their information on it, like name, MRN, etc., but also have a barcode on it. And so nursing and providers can use that barcode in order to ensure that it's actually the right patient, right? So it doesn't circumvent you going, hey, are you Joe Smith? Date of birth, XYZ. But the barcode scanning does help and provides another countermeasure to prevent medication errors. right dose, you want to make sure that we're ensuring the correct dose based on several patient factors. So things looking at the age of the patient, how you dose a medication based on the dose you give, either on a mg per kilogram basis or based on how frequently you give it, may be determined by the patient's age. You're going to be dosing a neonate very differently than you may a full adult, right? Gender may play a role. Pretty rarely does gender play a role on changing the dose, but in some cases it could. But then looking at things like renal and hepatic function, are you addressing a patient's ongoing changes in renal function and hepatic function over time? A dose of a medication may have been appropriate, say, 2 years ago, but now the patient's had some deterioration of their renal function, and now they may need an adjustment of their dose. And so is someone following that to make sure doses are being adjusted appropriately? And then looking at things like home medication reconciliation being extremely important for inpatient encounters. And so a lot of times med recs are not done very thoroughly, and which can lead to some very significant medication errors, right? So a really good example of this, I think drives the point home, would be a case where in an ER, a patient was asked what medications they take. And this person happened to be a drug-seeking patient, and they said, "Oh, well, I take methadone. I take 50 milligrams, say 6 times a day." It's a pretty big dose. Not unreasonable. It's not unheard of. Certainly, patients who have very significant opioid dependencies may be on that big of a dose, or significant pain conditions may be on that kind of dose. But whoever was taking the medication reconciliation just said, "Yep, sounds good," wrote it down. Patient got admitted with that on their record. The physician reordered it as such. The patient was lying through their teeth, though. No one actually did any follow-up and actually called their pharmacy to see what or their methadone clinic to see what they're actually taking. Patient was actually taking probably a quarter of that actual amount per day. And so order got put through. The doctor wrote it, pharmacist verified it, nurse gave it, found the patient completely comatose the next morning. Patient was able to be resuscitated, gave him some naloxone to reverse it, gave him some oxygen. Patient did okay. But again, you have to remember that sometimes, especially for these high-risk medications, you may need to do some backtracking and actually go back to the source, namely the pharmacy, to figure out what exactly they were taking. Getting the right route of the medication can also be more problematic than you might think in some cases, but always make sure that we're giving medications via the correct route and the intended route. So a good example of where this can be fatal if given incorrectly would be a drug like vincristine. It's a chemotherapeutic drug. And a lot of times, especially for things like leukemia, this drug is given in combination with other chemotherapy drugs in order to help eradicate tumor cells. And so you'll see sometimes 2 or 3 drugs being given at a time in order to treat a particular cancer. And so sometimes you'll see patients will get intrathecal medications as well. So something like methotrexate will be given in an intrathecal space the same day they're getting vincristine, say, IV. And so the issue can pop up as if something like vincristine is given via the wrong route and given intrathecally, it's fatal for that patient, right? So lots of medication errors have occurred with this over time, and so it's led to a lot of the medication safety initiatives in order to help prevent this. So for instance, instead of giving vincristine and distributing it in a syringe, which syringes are more likely to be mixed up and given intrathecally, it'll only be sent out and say in bags, like an IV bag, because again, you would never hook that up to a patient via the intrathecal route. So things like that can help to ensure that you're using the right route and prevent morbidity and mortality. Sometimes you'll see certain medications being given via non-traditional routes, and that may be okay, but it's important to be at least comfortable with it beforehand, or at least be able to look up references and make sure you're doing it via the right way. So say for instance, using a laxative in the ear. I was pretty confused the first time I heard that, but sometimes if you have impacted cerumen within the ear, you can actually use a stool softener like Docusate or Colace, put it in the ear, and actually will help to emulsify that cerumen and help it to loosen it up and so you can actually get rid of it. In some cases, you may be able to give oral products intravenously. So an old example of this would be something like N-acetylcysteine. Is a common medication used for acetaminophen poisoning. Back in the day, we didn't have an IV product for this, and so we used to have to give the oral product intravenously for patients that couldn't take it orally. So nowadays, we have an IV product, but just as a point of comparison, sometimes you may give oral products IV, sometimes IV products can be given orally. You can also have issues where medications may cause tissue irritation or necrosis if given via the wrong route. So for some good examples of this would be something like phenytoin, which is an anti-epileptic. If given intramuscularly, you can see tissue necrosis that can occur based on the high pH of the product. It's about a pH of about 11. So they have a more water-soluble form that can be given intramuscularly, so that would be phosphonitoin. But if you get that mixed up and gave phenytoin IM instead of phosphonitoin, that could lead to significant adverse reaction. And then another example would be something like vitamin K or phytonadione. Oftentimes you try not to give this intramuscularly if you can, because it may cause a hematoma in some cases. And so this may be a route where giving an IV may be a better option, or maybe giving a sub-Q in some cases. So just be aware that some drugs will have multiple routes that can be given by, and to be comfortable in ensuring that the patient is getting it via the intended route. And then right time is also going to be critical for a number of medications. So making sure that we're giving medications at the correct time, in the correct order in some cases. So say for instance, if you have something like acetaminophen being given as an analgesic, if this were being given too often, or if a patient was not educated appropriately and you told them that, okay, we'll take this every 6 hours, and they say, well, every 6 hours is fine, but I'm going to take it every 4 hours. That could potentially lead to some very significant hepatotoxicity. If you have pain medications, patients are taking it too frequently, they could lead to increased sedation. Certainly if you have something like contraception not being taken appropriately, something like emergency contraception like Plan B, in particular, if not taken within an appropriate amount of time after unprotected intercourse, that could lead to failure of therapy, and you may potentially have a pregnancy on your hands. And then something like antibiotics are very, very time critical, where if they are not given at the correct times and they're given too infrequently, it could lead to subtherapeutic levels within the blood, and can lead to worsened infection, can lead to resistance by the bacteria, and so timing of antibiotics is a big initiative for a lot of hospital kind of medication safety initiatives, to make sure that, especially for things like pneumonia or for sepsis, antibiotics are given in an appropriate time, not only initially but also for subsequent doses as well. So that's it for adverse reactions. Now we'll move on to talking about bioavailability and bioequivalence. Just for some definitions, we've talked a little bit about bioavailability previously, but again, this is going to be the fractional extent to which a dose of a drug is going to be reaching its site of action regardless of the route of administration, right? So it's just every drug, depending on how it's being given, will have some amount of bioavailability. For some drugs, maybe 100% by a given route. Some drugs will be 0%, depending on the route. There's also another term called bioequivalence. This is going to be when two different drug products contain the same active ingredients and are identical in their strength and concentration, their dosage form, and also the route of administration. And so this is going to be really important when we talk about generic drugs, because in order for a generic drug to be interchangeable with, say, a name brand product, they have to show bioequivalence, and we'll talk more about what that means in a little bit later. So bioavailability can be altered by a number of different things, and some of which we've already talked about previously, but some new things we'll talk about, including the route of administration it's being given by. Obviously, some routes are going to be more efficient at getting the drug into the bloodstream versus others. The acid-base status of the drug, the acid-base status of the environment that the drug may be absorbed in, the actual absorption that occurs. So say if you have some interacting drugs or other things that could be preventing absorption that can affect the bioavailability. And we'll also be talking about things like the bound percentage versus the unbound percentage of the medication, how that affects bioavailability. First pass effect, which is really important when things are first absorbed from the GI tract. Again, the liver kind of is going to be the first organ that the drug encounters, and will lead to some degree of degradation of the drug product prior to getting into systemic circulation. And then we'll also talk a little bit about excretion and elimination of the drug as well. So looking at the route of administration, we can see here that we've looked at this table before, but bioavailability can be pretty wide-ranging depending on how it's being given. So, for instance, IV, you can be pretty much guaranteed you're going to have 100% bioavailability because you're, again, directly putting it into systemic circulation. IM subcutaneous, again, is going to be pretty high bioavailability. And again, you're bypassing the first pass effect that you'd see with the oral route of administration. Once you get past that, though, it's going to be a little bit more dodgy depending on the physiochemical properties of the drug and where it's trying to be absorbed from. So again, some drugs may be absorbed very well through the GI tract when given orally, but if they are degraded by the liver to such a degree that not very much of it gets to the systemic circulation, that's going to have pretty poor bioavailability, and so the oral route may not be great for that, right? So just be aware of the kind of the general comparisons between bioavailability between something that's maybe given intramuscularly versus something that may be given, say, inhalationally or orally. So we talked about acid-base topics before, and again, we'll talk about it specifically with absorption of the medications here and bioavailability and how it pertains to that. Again, keep in mind that a lot of times when we're talking about biological solutions, especially when we're talking about things like blood, it's generally going to be pretty tightly controlled for the most part. Again, you'll see that general pH for the serum should be anywhere between, say, 7.35 and 7.45. And you'll see that in some cases it will lead to things like trapping of medications depending on which type of pH it's going to be partitioning into. So things like, breast milk obviously is going to have a different pH, which can lead to trapping of drugs. But when looking at things like gastric acid having a very low pH, we'll see that things like the duodenum is going to have a higher pH based on its acid-base status. So all of this can have an effect on how well the drug is going to be getting absorbed, again, depending on the solution that the drug is in and also the acid-base status of the drug itself. So just some comparisons of drugs that are weak acids versus weak bases. And again, this is all going to be really important when we're looking at things like, where is a drug best absorbed from? And again, that's all going to go back to its pKa in comparison to the pH of the solution that it's in. And remember that when we're talking about this, that in general, it's easy to remember that like dissolves like. So if a drug, say something like acetaminophen, has a pKa of about 9.5, again, when it's at a pH of 9.5, it's going to be at a state where it's 50% ionized and 50% unionized. Again, and we're going to want to tip that to a point where it's going to be more in the unionized state, in which case it's going to be better absorbed. So in this instance, by acetaminophen being a weak acid and having pK of 9.5, just by having a solution of 7, which is going to be more acidic than its pKa, you'll see that a higher proportion of it's going to be in that unionized state, and this is going to be better absorbed. So again, this is all going to be dependent on the drug itself, and a lot of times the dosing of the drug has already been kind of figured out to account for a lot of this stuff. So it'll account for the bioavailability that the drug's going to have when given via a given route. So just for review, again, water molecules, which are polar, are typically going to be attracted to charged drug molecules. So the more charged the drug is, the more the higher proportion of that drug that's in a charged state, more water soluble it's going to be. And then conversely, the lipid solubility is going to be inversely proportional to its charge. So the more drug we have, the higher percentage we have in an uncharged state, the better lipid solubility you're going to have, right? So again, this is really important for drugs to be able to cross biological membranes in order to get into systemic circulation. Again, just like we've seen in polar water, again, because it is polar, something that has a charge is going to be much more attracted to it, and this is going to be much more soluble in it. So a good example of this is going to be aspirin, which is a weak acid. Meaning that it's typically a neutral molecule that can pretty easily and reversibly dissociate into an anion and a proton. Again, when it's in this neutral state, the protonated state, it's going to be more lipid soluble versus when it's charged, when it's separated, it's going to be typically more water soluble. So if you look here at the bottom, again, when aspirin is in a neutral composition, again, it's going to have this hydrogen ion attached to it. It's going to be more lipid soluble because it's in an uncharged state, versus if you were to put it into a different type solution, you're going to see it's going to be dissociating into the aspirin anion plus the proton. Because it's a weak acid, if you were to put it into a more acidic solution, you're going to be kind of shunting the direction, the formula over here to the left side. We're going to have more of it going to be in this neutral configuration, versus if you were to put it into a more basic solution, you're going to see more of this dissociation occur, and this will have more of an anion. So obviously again, like dissolves like, a neutral aspirin molecule in an acidic solution is going to have a much easier time being absorbed from the GI tract than you would see with in a more basic solution. This might be a case where something like aspirin gets better absorbed from, say, like the stomach, where the pH is much lower than it would, say, in the duodenum, where the pH is starting to get a little bit higher. Another kind of opposite example would be something like pyrimethamine, which is a kind of an old school antibiotic. It's a weak base, and so again, this will be an example of a drug which is a neutral molecule that can form a cation by combining with a proton. So here, when it's neutral in the unprotonated state, it's going to be more lipid soluble, versus when it's in a protonated state, it's going to be charged, thus it's going to be more water soluble. So here in this situation, if I were to have pyrimethamine here in its natural state, if I were to put this into a more basic solution, I'm going to drive the reaction here to the right here, and thus I'm going to have an easier time being absorbed than if I were to put it into a more acidic solution, more hydrogen ions floating around, more protons. It's going to be more in this charged state. It's going to have a harder time getting absorbed through lipid membranes, but have an easier time being dissolved in water. We talked about the Henderson-Hasselbalch equation before, but again, this protonation is going to be the combining of a molecule with a proton. And again, here with the weak acids, we'll see that the protonated form is neutral, versus with weak bases, the unprotonated form is neutral. Again, uncharged or neutral molecules are going to be more lipid soluble, whereas charged molecules are going to be more water soluble. Again, we're looking at pH and pKa. It's important to keep this relationship in mind, that when a drug is in a pH, the solution of the pH is the same as the pKa of the drug, you're going to be seeing that you're going to have basically a 50-50 split between the unionized and the ionized state here, the charged or the neutral state. And so based on how you shift that pH, you're going to see a higher proportion. It's going to be one state versus another. And so by manipulating the pH of the medication, you can or manipulating the pH of the solution that the drug is in, you have either easier or harder time for it to be absorbed, and thus you may have a better or worse bioavailability of that medication. And so going back to our Henderson-Hasselbalch equation, again, it can be pretty easily explained by looking at the formula here, where our log of the protonated versus the unprotonated state is going to equal pKa minus the pH. Again, this has been kind of rearranged from what we've seen previously. But again, just keep in mind that if you had a pKa that was the same as the pH of the solution, obviously this would equal out to be 0, which would mean that the 0 is equal to the log of 1, so 1 over 1. It means you had that 50-50 ratio there. And so again, this is really just showing us that in the uncharged form is going to be more lipid soluble, so that for acids, the uncharged form is going to be protonated, versus bases, the uncharged form is going to be unprotonated, right? So it's just reiterating what we've already seen. And then basically the end all of this is going to be that more weak acids will be lipid soluble at acidic pHs, and more weak bases will be lipid soluble at alkaline pHs. So like dissolves like. One thing we'll kind of touch on how pH is important will be with drug elimination. I kind of touched on this briefly previously, but we'll talk a little bit more about it here. Specifically, we're going to be mostly talking about renal elimination of these medications and how pH can affect that. Again, Henderson-Hasselbalch can be important for excretion of medications. Again, we'll see that weak bases are usually going to be excreted faster in acidic urine, whereas weak acids are going to be usually excreted faster in alkalotic urine. And the reason for that is because medications that are in an uncharged or neutral state, they're going to have an easier time being reabsorbed by the renal tubules. So in order to help prevent that from occurring, by having a molecule in a charged state, it has a harder time being reabsorbed, and thus it can be carried out in the urine and excreted upon micturition. So in this case, when you have a weak base that's going to be in a acidic urine, again, you're going to have a higher proportion of it's going to be in that charged or protonated state. And then on the flip side of that, in an alkalotic urine, weak acids will typically be in a more charged, unprotonated state, and thus in both situations you'll have faster excretion of the drug molecule. Again, a good example, typically you see urine mostly being in the mildly acidic, usually anywhere between, say, 5 and 7 for most cases. And we know that by giving sodium bicarbonate intravenously, we can end up seeing urinary alkalinization, where we can actually increase the pH of the urine. So based on knowing that, if we were to give sodium bicarbonate to a patient who was receiving phenobarbital, which is a weak acid, how do we think that's going to be affecting the renal excretion of that medication? Well, if you think about it as being a weak acid, and you say, okay, well, if I have a weak acid and it's in the urine, it's in the renal tubules, and I increase the pH, that means I'm going to be in a situation where I'm going to have more of the drug being in the unprotonated state, because it's in a more alkaline solution, which means I'm going to have a higher proportion of that drug being in a charged negative anion state, which means it's going to have a harder time being reabsorbed through the renal tubules, because again, it's going to be less lipid soluble, and thus it's going to have an easier time being excreted within the urine. And in fact, this is a good way you can actually use to help increase the elimination of drugs like phenobarbital for patients that maybe have, say, overdosed on phenobarbital. You actually increase the elimination of the drug in order to help get the patient down to a therapeutic level more quickly. So just some examples of how we can kind of apply all of the things we've kind of talked about thus far. So for example, say we have a drug like propranolol, which is a beta blocker. It's used somewhat frequently. And say our dose we're going to be giving here is going to be 160 milligrams, 1 tablet by mouth daily. So looking at this, say we have, looking at propranolol's absorption. Propranolol is highly lipophilic, has a pK of 9.4. Do we think it's going to have good or bad absorption? We're just looking at that, noticing that we have high lipophilicity. That's going to tell us that, well, we're going to have an easier time crossing those GI membranes. We're going to have an easier time crossing the GI tract. So yes, I think it's going to have good absorption based on that. Then looking at the first pass effect, approximately 25% say reaches systemic circulation. So that means we have a pretty decent amount of the drug being chewed up by the liver as it is getting into systemic circulation. So based on that, how much of the dose do we think makes it to systemic circulation? So just based on this problem here, we'll just say for easier calculations, based on lipophilicity, we'll just assume that the absorption is going to be 100% here, right? And so we're really just going to be looking at the first pass effect specifically. So again, if approximately 25% reached the systemic circulation, how much of the dose do you think makes it into this systemic circulation? Well, it'd be 25% of that 160, so it's going to be 40 milligrams reaches the actual bloodstream. One of the next things we can also look at are going to be the metabolism of propranolol. And so looking at the half-life of the drug, let's say that it has an approximate half-life of 6 hours. So based on that, if you're looking at metabolism of the drug over time, you'd see that at initial time 0, so this is say when all the drug has been absorbed to the GI tract, the total body level of propranolol is going to be 40 milligrams. And then based on this, we can say that at 6 hours, okay, that's one half-life. Well, it should be at 20 milligrams. At 12 hours, again, that's been another half-life, so we're going to have half of the drug left, because again, this is following first-order kinetics. So again, a constant percentage of the drug is being metabolized per unit of time rather than just a constant amount. So again, the first half-life will be 20 milligrams metabolized, the second half-life 10 milligrams, and so on and so forth. You can see here to where at 24 hours, we only have about 2.5 milligrams left of that initial dose left in the body. This is kind of simplistic, but this is good for kind of illustrative purposes. Looking at the distribution of the drug once it actually gets into the systemic circulation, let's just say that approximately 90% of circulating propranolol is going to be bound to plasma proteins. And specifically, this is going to be bound to one called alpha-1 acid glycoprotein. So when looking at this, you can say that, okay, well, 40 milligrams reach the systemic circulation. I know that 90% of it's bound to this alpha-1 acid glycoprotein. That means about 36 milligrams is going to be the bound fraction, whereas the other 10% of the 4 milligrams is going to be unbound. And so then the question is, well, which fraction is going to be pharmacologically active? Well, we know that unbound drug is going to be active drug, because again, if the beta blocker is stuck on alpha-1 acid glycoprotein, it's not going to be available to sit there on the beta receptors in the heart. So the unbound fraction is going to be what's pharmacologically active. This is also going to be the fraction that's going to be available to be metabolized when the drug eventually goes to the liver. So this is why it's really important to take into consideration protein binding interactions that can occur, because say this is a therapeutic level, having that 4 milligrams being unbound, but what if I had another drug that also wanted to bind to alpha-1 acid glycoprotein and kick more of that drug off to where, say, now I have 20% that's unbound? Well, I just doubled my effective dose and may lead to some increased side effects from the propranolol. So let's take another step further. Let's look at the volume and distribution of propranolol. Let's say we have a 70 kilogram male, and we administer 160 milligrams to that patient via the oral route. So we know that because 75% of it gets metabolized by the liver, and that's our first pass effect, we're going to have roughly 40 milligrams that gets into the systemic circulation. So based on that, we drew a serum level right after the patient absorbed all that drug, and we got a serum plasma concentration of 0.14 milligrams per liter. So based on that, what is the volume of distribution for this patient in liters? And then what's the volume of distribution in liters per kilogram? Because again, we oftentimes will see that drugs' volume of distribution are going to be expressed in liters per kilogram, because that way it makes it more comparable between different types of drugs and for different sizes of patients. So how would you figure that out based on the information that we have? Well, again, going back to our equation that we've seen in previous units, we know that our C0, or that our initial concentration, which in this case would be measured as milligrams per liter, is going to equal the dose that we give. Is going to be our D in milligrams over our volume of distribution in liters. So if you rearrange that, you would see that volume of distribution in liters is going to be equal to the dose that we administered over our C0. So again, plugging all the variables into that, we would look to see, for our drug that we administered, again, this is going to be 40 milligrams. It's not going to be that initial 160, because that 160 wasn't actually what reached the systemic circulation. Now, say we were to give that propranolol IV, then at that point the D would be 160, because that's, you would assume 100% of bioavailability. But in this case, it's going to be 40 milligrams, and that's going to be divided by the concentration that we have, or C0. And so that's going to be 0.14 milligrams per liter. So I'm going to divide that out. And basically what I get is that my volume distribution is going to be 286 liters. If I divide that by what the patient weighs, I'm going to have 286 divided by 70, and that's going to give me a volume distribution of 4 liters per kilogram. So one of the things we saw previously that we said was propranolol is pretty lipophilic. And so that means it's going to like to distribute into the tissues preferentially versus the systemic circulation. And so having a volume distribution of 4 liters per kilogram is going to be in general pretty high. I mentioned it before, but anything that has a volume distribution greater than 1 liter per kilogram is generally considered to be high, versus things that are low volume distribution will have a volume distribution less than 1 liter per kilogram. So again, by using that kind of general comparison, you can kind of figure out how much a drug, how lipophilic it is and how well it likes to distribute to the tissues. So in this case, propranolol is very lipophilic, and that's just going to have a high volume of distribution. Okay, so we'll do another example with propranolol, try to kind of get all steps in the process figured out. So again, looking at propranolol given to a 50 kilogram female, let's say the administered dose is going to be 120 milligrams in this case, And again, based on our references, we know that the volume distribution is going to be approximately 4 liters per kilogram. So based on that information, what is the concentration in the plasma going to be once we had that drug, that dose absorbed? So again, looking at this, or we're trying to solve for C0, right? Because we want to figure out what our approximate concentration is going to be. So in here, we want to look at the dose over our volume distribution. So when plugging all of this in, we'll see that X, or C0, is going to equal 30 milligrams, because again, we have 75% that drug being metabolized. So 25% of 120 is going to be 30 milligrams. So that'll be our dose. And we know that our volume distribution is 4 liters per kilogram. So we would do 4 times 50, because the patient weighs 50 kilograms, to get what our volume distribution is. So for her, it's going to be 200 liters. So we would take our dose, 30 milligrams, divided by 200 liters, and then our X, or our concentration, should be 0.15 milligrams per liter. Right, so based on kind of population kinetics and based on what we know about the patient, we can kind of estimate what her serum concentrations would be. And if this was a drug that had established therapeutic levels, we can figure out if that dose would be appropriate for her, or if maybe we need to increase or decrease it to get into a therapeutic range. So let's say we wanted to figure out a different variable. Let's say we were administering propranolol to a 100 kilogram male, and the concentration in the plasma that we measured after he received a dose was 0.05 milligrams per liter. And again, we know the volume distribution based on population kinetics is approximately 4 liters per kilogram. And so based on this information, what dose did the patient receive, do we think? So again, looking at our initial formula, we see that our dose, or D, in milligrams, is going to be equal to our C0 times our volume distribution. Again, we're just kind of rearranging it, pretty basic algebra here. So dose equals C0 times our volume distribution. So in this case, if we plug everything in, we'll see that 0.05 milligrams per liter times our volume distribution, which for him is going to be 400 liters, because again, the volume distribution is 4 liters per kilogram times 100 kilograms. So we'll have 0.05 milligrams per liter times 400. And then what it's going to equal to is 20. So 20 milligrams is what the serum level was in the patient, or the serum amount that was ingested by the patient. So again, going back and knowing that he had 75% of that dose was first pass, basically you can figure out that, okay, that 20 milligrams was originally 80 milligrams that the patient had ingested. Again, if you have any issues with this, or problems, or questions, feel free to email me, and I can try to clarify it for you further if any of this doesn't make sense. So again, putting it all together, let's say we were working with a new drug, say it's called sarcastanol. It's meant to help to suppress the sarcasm in PA students and pharmacology teachers alike. We'll say this drug is a weak acid. It's a pKa of approximately 5.4, has a bioavailability of 90%, which means that 90% of a dose that's ingested would be absorbed. Has a volume distribution of 0.2 liters per kilogram. And again, remembering what we said before, is this a high volume distribution or low volume distribution? Well, in this case, it would be a low volume distribution because it's less than 1 liter per kilogram. And the package insert says that the dose is going to be 500 milligrams every 6 hours. For this drug, what do you think would be the expected serum concentration after a 500 milligram dose was ingested by a 70 kilogram male? Again, since we're solving for C0, we're going to do C0 equals dose divided by volume of distribution. So our dose, again, based on the bioavailability, we know that's about 90%. So 450 milligrams would actually be absorbed. So that's going to be our dose in this circumstance. And then looking at volume of distribution, we know that our volume of distribution is 0.2 liters per kilogram times our 70 kilogram male means our total volume of distribution would be 14 liters. So if we divide that out, it would be 450 milligrams divided by 14 liters. C0 should equal 32.14 milligrams per liter. So again, pretty straightforward math. Again, you might be asked to calculate something like this on an exam, but it would be pretty easy math. So I'm not going to expect you guys need to bust out a calculator necessarily, but at least have the concept down and how these different variables interact with one another. And so when taking that into account, look at something like volume of distribution. What effect do you think volume of distribution really has on serum concentration as compared to something like propranolol? We said that this has a volume distribution of 0.2 liters per kilogram, which we said was low compared to something like propranolol, which is 4 liters per kilogram. So what does that tell us about the drug? Well, it means the drug likes to be more in the systemic circulation, does not like to distribute as much out into the tissues. And so as such, even if you're giving an equivalent dose based on bioavailability and all other factors being equal, the serum concentration of a drug with low volume distribution is always going to be higher than a drug with a high volume distribution, right? Just because there's less drug in the serum to actually measure, right? For a high volume distribution drug, it's just going to be distributing out to the tissues. So keep that variable in mind, and keep in mind how that's going to be affecting serum concentrations based on different volume distribution. Okay, so in the next scenario, let's say we had a 45 kilogram woman who's taking sarcastanol and is now experiencing an excessive amount of sarcasm. Maybe she's having a paradoxical reaction, something to this, but now she's being extra sarcastic. So we try to figure out what's going on, so we decided to do a serum blood level and get a level back of 75 milligrams per liter. So based on what we know, what dose do we think she took? So again, and this is kind of a simplified way of looking at it, but let's just assume that she'd just taken a dose, she just absorbed it all, and this is now when we got the serum level. So based on this, we can look to see what her actual dose was. So again, if you remember, C0 equals dose over VD. We can just rearrange that so that our dose is going to equal C0 times our volume distribution. Volume distribution is pretty easy to figure out because we just do our 0.2 liters per kilogram times our 45 kilogram woman, which would equal 9 liters. So 9 liters would be the total VD. And then we know our C0 is 75 milligrams per liter. So we just multiply that out. 75 times 9, we get 675, right? So that would be the amount that was actually in the serum. But remembering that we have a 90% bioavailability, we want to figure out the actual dose she took. So we just tack on an extra 10% to that, and you get a total dose taken of 750 milligrams. So that would be your answer. She's taking 1.5 times the normal dose that would be recommended normally. Okay, and then just for something that you wouldn't really normally do in a clinical scenario, but let's just say, just to kind of show you all aspects of the kind of utility of that equation, that C0 equals dose over VD. Let's say we had a 45-year-old male who took a 500 milligram dose of sarcastanol, and now he has a plasma level of 20 milligrams per liter. How much does that patient weigh? And so you could actually still figure that out based on what we know. So again, let's say he took 500 milligrams. We know that 90% made it into systemic circulation, so we'll tack that down to 450 milligrams in the bloodstream. We know what his plasma level is going to be here. So again, we just kind of back calculate this and rearrange the equation to be volume distribution equals dose divided by C0. So we'll do our dose of 450 milligrams divided by our concentration of 20 milligrams per liter. And that's going to equal 22.5 liters. Okay, so that's his total volume distribution, but if you want to figure out what his weight would be, you just take that 22.5 liters, divide that by the actual volume distribution of 0.2 liters per kilogram, and it ends up being 112.5 kilograms this patient weighs. So again, just another example how you can kind of manipulate the variables to figure out another unknown based on kind of given information. Okay. The last thing we'll talk about today is going to be bioequivalence. Again, this is going to be when two different drug products contain the same active ingredients and are identical in strength and concentration, their dosage form, and route of administration. And again, this is going to be really important for generic drug manufacturers to prove in order to get their their drug product out on the market. So again, oftentimes you'll be looking at tables like this to prove bioequivalence between two different drugs. So in this example, you have two different bupropion products. This is an antidepressant. It works as a selective reuptake inhibitor for things like dopamine. But here you see that both of these are an XL formulation, which means they're an extended release, extra long-acting product. And you can see here that both are 150 milligram products. And so what you would do to prove bioequivalence is to give both products to people and measure serial blood levels. And if you can show that they're similar enough, I mean they have similar time to peak levels and they maintain similar drug levels throughout the duration of the drug, then it would be considered to be bioequivalent. And thus you could easily substitute one for the other and the patient should have the same therapeutic effect. So just a few more definitions. So for pharmaceutical equivalents, these are going to be products that have the same active ingredient, same dosage form, same route, same strength and concentration, but the things that can change are going to be things like the shape of, say, the tablet or the way it's scored. So whether it's scored down the middle or no scoring at all. May have differences in release mechanisms, packaging may be different, and also excipients, the other kind of inactive ingredients that are in the dosage form. So this would be for like two different manufacturers of the same drug product. They may have a different color or a different shape, and so that's typically the situation you'll see kind of pharmaceutical equivalents. A lot of times you'll have patients who will come up and say, well, only the blue version of that pill works for me. All the other ones don't work. Well, generally, if they're considered to be bioequivalent, they should have the same exact efficacy and same exact side effect profile. They should work exactly the same. You'll see there's some psychogenic kind of effects happening here. People will believe that the brand names work better for them. Could be some merit to that, but in a lot of cases, the generics will work just as well. Just because they look different or have a different color does not mean they'll necessarily work any less effectively. You also have pharmaceutical alternatives. These will have the same therapeutic moiety, but are potentially different salts, esters, or complexes of the same drug. So for example, tetracycline hydrochloride versus tetracycline phosphate complex. Now, you could have completely different kind of release profiles for these drugs. One could be short-acting, one could be long-acting. And so these drugs are, while they're the same drug product, they may not be necessary therapeutic equivalents. And so a therapeutic equivalent is something that has to be a pharmaceutical equivalent, and they need to be able to show they have the same clinical effect and the same safety profile. And so they have to kind of meet the following criteria. So they have to be an approved product by the FDA. They have to be shown to be safe and effective. The two products must be considered to be pharmaceutical equivalents. They have to have the identical amounts of the active drug ingredient in the same dosage form, in the same route of administration, and based on the graph I showed you previously, they have to be considered bioequivalent, right? So they have to be able to have the same drug levels or similar enough to be approved as being a therapeutic equivalent. So this way I can say, well, brand name Prozac is fine and all, but I can use a generic that's been shown to be a therapeutic equivalent, and I'll have the same exact efficacy based on these criteria. The way that we figure out if drugs are bioequivalent is based on this resource here. It used to be an actual published book. It was orange in color, and so they called it the Orange Book. Now it's all available online. And essentially what this does is help us to compare different drug products to figure out whether or not they're bioequivalent. So it's published online by the FDA, and they have different therapeutic equivalence evaluation codes. Again, these help to determine if the products are considered to be a therapeutic equivalent or not. The basic thing that you should take away from this, if you ever have the opportunity to look at the Orange Book, is that A ratings can be considered to be therapeutic equivalents, and they can be interchanged. Whether it has an AA, AB, AO rating, whatever it happens to be. Don't worry about the second number there, just worry about the first A rating. Those items can be interchanged. A B rating, on the other hand, will be things that are considered not therapeutically equivalent. The release characteristics or the blood levels are different enough to where they are not considered to be equivalent, and thus if you write for a script for prescription for this product, it cannot be interchanged with something else that's not considered to be bioequivalent, right? On the other hand, though, if I write for a brand name drug on a prescription and I don't write, dispense as written, so that I have to dispense the brand name, as long as it has an A rating, I can switch it out and interchange it for a generic product, no problem. And you'll know that it'll be a therapeutic equivalent that'll work just as well for the patient. So just an example here, we're looking at propranolol. You can see here, if I pull up my laser pointer, that here you have some AB rated products here that all would be considered to be therapeutic equivalent. So here we have hydrochlorothiazide and propranolol combination product. All of these products would be considered to be therapeutic equivalents, right? Because the same drug products, same dosage form, same strength here. So 2540, 2540. These would all be considered to be therapeutically equivalent. On the other hand, though, if you were to look at, say, these propranolol capsule extended release products, here you see BX rated. So because there's that B rating, that would not be considered to be therapeutically equivalent. You would not be able to interchange those without some difference in therapeutic efficacy for that patient. Now, whether that's clinically relevant or not, not really hard to say. It would be kind of dependent on the specific situation, but again, for prescribing purposes, that would be something you could not interchange unless you wrote for it specifically. So that finishes up this section. Again, if you have any questions, please feel free to email me. I'll try to address them on the next week's video. But if nothing else, I will talk to you guys next time.